Hello, everyone. We are very happy you're here. I would like you, I would like to welcome you to our webinar, supporting survivors at the intersection of domestic violence and problematic substance use. My name is Jess Hoover, and I'm the digital learning specialist here at PATHS. And today I am joining you from Treaty 4 territory. PATHS and our member agencies support individuals living on Treaty 2, 4, 5, 6, 8, and 10 territories, the traditional lands of the Naheawak, Anishinaabeg, Dene, Dakota, Lakota, Nakota, and the homeland of the Métis and Michif nations. We recognize the historical and ongoing harms of colonization, and we're committed to moving forward in the spirit of reconciliation. The Provincial Association of Transition Houses and Services of Saskatchewan, or PATHS, is the member association for agencies that provide emergency shelter and counseling to survivors of intimate partner violence in Saskatchewan. We support our members through research, training, providing opportunities for peer support, advocacy, and public education on the issues surrounding violence against women. Today, I'm going to be joined by my colleague, PATH's Director of Research, Dr. Crystal Giesbrecht. She's going to be facilitating our Q&A at the end of the presentation. And I'm very pleased to introduce our speaker, Savanna Belitski. Savanna is a registered social worker in Saskatchewan with 6 years of experience in the gender-based violence field. Her work supporting survivors motivated her to pursue a Master's of Social Work, where the thesis focused on combined programming to support survivors of domestic violence experiencing co-occurring problematic substance use. This work was informed by interviews with professionals from across Canada. Her research explores the specific motivations, theoretical approaches, policies, successes, and barriers in implementing combined programming for this population. This webinar provides a detailed description of these findings and offers actionable recommendations for agencies and professionals interested in improving available supports for a population who is deserving of specialized evidence-based care. Lastly, a couple of housekeeping items. All participants will have their microphones and cameras off for the duration of the webinar. If you think of any questions as Savanna is presenting, we encourage you to pop them in the Q&A, and that way we won't miss them. The chat should be open for general discussion. And if you have any technical difficulties, please directly message Crystal or myself, and we will be happy to help you out. The webinar is being recorded, and you will be sent a link after the presentation is over. So with that, I will turn it over to Savanna. Thank you.
Thank you. I'll just get my slides going here. Okay, there we go. So first, I just want to start out just thanking everybody for their time this morning. This is a project that's really close to my heart, so I really just appreciate everybody being here and the opportunity to be able to share findings from the research. So as just mentioned, I'll be sharing the findings from my research, which explored really the practical features and the day-to-day elements that inform effective combined programming to support women who are experiencing co-occurring domestic violence and problematic substance use. And my interest in this project really came from my own professional experiences working in domestic violence shelter and really seeing the barriers experienced by women who were accessing a domestic violence program, but were also experiencing challenges related to their substance use, and really seeing that as much as myself or my coworkers wanted to do our best to support this population, really seeing that these women were consistently falling through the cracks of services, and really seeing that there was something missing in our program to be able to support these women effectively. And with that as well, when I was shifting towards pursuing my master's, I also saw a lot of really incredible change happening within the agency to better support women who use substances and really begin to implement harm reduction and combined services. So I became really curious about what other agencies across Canada were doing in this area and what best practices in this area could look like. So I really pursued this research with the intention of wanting to really highlight the voices of those professionals who are working on the front line, who are working directly with this population, really to be able to garner some practical insights and recommendations for professionals who are interested in improving services in this way and really committed to serving this population the best way that they can. So what I will be talking about today is first sharing some background information on the interconnection of domestic violence and problematic substance use, and some research on what programming has looked like in this area. And then I will share some brief overview of what the study itself actually looked like and what I actually did in the research. And then we'll be spending majority of the time sharing the specific findings and recommendations for practice in this area. So looking at, so I need to figure out how to move my screen here. There we go. So just to start, I want to clarify some of the terminology that's being used in the research. So the study specifically looked at combined programming. And in the context of this research, combined programming refers to a single program or service that pays combined attention to the intersection of domestic violence and problematic substance use as a core element of service design and delivery. So there's been a lot of recent research and recent attention into how harm reduction practices can be incorporated into domestic violence agencies in order to be more responsive and inclusive to women who use substances. But I wanted to go a little bit of a step further in this particular study to look at combined programming that specifically addresses problematic substance use, as opposed to more general policies and general practices to be more responsive. And obviously, combined programming was looking at domestic violence, which we know is an intentional, ongoing, and systematic abuse, really intended to exercise power and control over an intimate partner, and takes many forms, including physical, verbal, psychological, sexual, economic, among others. And then I also wanted to just note that the terminology used for this research was problematic substance use, really to be defined as a maladaptive pattern of substance use that results in significant impairment or distress in an individual's life. And this terminology was chosen, one, to align with the most up-to-date academic language being used, and also to, again, reflect not just individuals who use substances, but really substance use that is causing significant impairment or distress, and then looking at how combined programming can address that specifically. So to share some of the background information that I looked at when conducting the study, first is obviously we know that both domestic violence and problematic substance use have serious and lasting impacts on an individual's health, both mental and physical, that there's connections to increased rates of anxiety, depression, PTSD, connections to trauma, to increased isolation, that all really have really impactful and long-lasting impacts on somebody's life. And what I found in the research was that there's really decades of research to show that there is a bidirectional relationship between domestic violence and problematic substance use. And bidirectional means that with experiencing either domestic violence or problematic substance use, there's an increased likelihood of experiencing the other challenge. And not just an increased likelihood, but also increased severity of both challenges when they occur concurrently. So while substance use may be a way that survivors cope with or manage the impacts of domestic violence, aspects of the substance use behavior may also be used as a really intentional abuse tactic known as substance use coercion. So tactics of substance use coercion could include preventing survivors from accessing substance use services, introducing and providing substances to keep survivors in vulnerable positions, and really reliance on that relationship and really limiting the ability for that person to successfully leave the relationship. May also include using a survivor's substance use as justification for inciting violence against them, coercion of sex in exchange for substances, or threatening child apprehension due to a survivor's substance use, among other tactics. So despite there being really strong evidence that domestic violence and problematic substance use are really intertwined, interconnected challenges, available programming has historically been siloed, meaning that it either addresses domestic violence or problematic substance use while really ignoring, excluding, or penalizing the other issue. So this could be a domestic violence shelter that takes an abstinence-based approach to substance use and doesn't allow women who use substances to access their services, or maybe an addiction treatment center that really has no screening or attention to the impacts of domestic violence. So these siloed approaches really, unsurprisingly, create additional barriers for women who have co-occurring needs. And there's really evidence to show that this population has really unique and complex service needs that are really ineffectively met by these siloed approaches. And further, research also shows us that when either concern is ignored in treatment, so for example, if we have a domestic violence shelter that is supporting somebody who is experiencing challenges related to their substance use, and that agency says, we don't want to discharge her or kick her out of the program, but we really don't deal with substance use. So we'll still support her with the domestic violence, but we're just not going to ask about substance use. We're not going to talk about that piece. Because substance use and domestic violence are so intertwined, and substance use coercion might be such a big piece of that violence, we're not only limiting the effectiveness of services, but we're actually actively putting that person at risk for greater harm when we're not looking at that piece. So there really is this necessity that we are addressing both of these things when they're both occurring in order to appropriately and effectively support individuals. So research has shown us that combined programming, which again is one program that has a combined attention to both domestic violence and problematic substance use, is a promising and recommended approach to addressing co-occurring client needs. And that is this research showing the effectiveness of that approach is really what led me to continue researching what this can look like in practice. So moving into the actual design of the study. So what I found in past research, which looked at combined programming or looked at harm reduction practices in shelter, really found that there was a lot of recommendation that agencies should be incorporating those approaches, but those recommendations were really at a high level or offered some really vague suggestions where there really was no detailed direction or detailed explanation for how agencies can actually go about incorporating that in their day-to-day practice. So when I was conducting this research, what I really wanted to look into was what are the specific motivations, theoretical approaches, practices, successes, and barriers that inform really effective combined programming to support women identified survivors of domestic violence experiencing co-occurring problematic substance use. And what I really wanted to accomplish was, again, highlighting the voices of the professionals who are already engaged in this work and really being able to garner some tangible, actionable recommendations for practice in this area. So I'm hoping that what I share in this presentation today will be able to provide a little bit more direction for agencies interested in this work. So to share what I actually did in the study itself, I first started out with the literature review, which gave us that background information that I talked about and really helped determine the focus of the present study. And then I took on the task of trying to identify agencies across Canada that were implementing combined programming. And what I found was that agencies engaging in combined programming was really limited across Canada, that there was a lot of responses saying that either agencies didn't do this at all, or maybe incorporating some elements of harm reduction, but really not to the extent that I was trying to look at. As well, the participants that I did recruit for the study also had limited knowledge on other agencies in their communities or in their provinces that were engaging in this kind of work, which really just speaks to the fact that agencies are left to navigate these changes really on an individual basis when there is that lack of connection to other agencies doing this work or lack of connection or direction happening from research. So for the participants that were recruited for the study, all of the participants worked at community-based organizations that offered combined domestic violence and problematic substance use programming. All of the agencies served women, though those majority of those services were also inclusive of other genders. And all of those participants had some sort of credential or training to support their work in this area. So then once participants were recruited, data was collected through semi-structured interviews with those professionals. So really looking into the day-to-day practices, what was working, what wasn't working, what recommendations they had for practice in this area. And then all of those interviews were coded and reviewed for themes in the research to help determine the key themes and findings from the study. And I believe Krista will be making the thesis itself available to participants of the webinar. So if anybody is more interested in specifically what the methodology pieces look like, that can be made available for you. And then just wanted to share some of the specific participant demographics. So ultimately in the study, I interviewed 10 participants from 9 community-based organizations. Of the agencies included in the study, 4 were emergency domestic violence shelters, 2 were second stage domestic violence agencies, which offer more long-term accommodations, and 3 were more generally defined community-based organizations, which housed both domestic violence and harm reduction services as separate services within the same agency. And all 3 of those generally defined agencies also included provision for either emergency or second stage domestic violence shelter. So while initially it set out to have more of maybe a general focus of any community-based organizations that were offering this kind of service, based on the participants that were recruited for the study, a lot of the findings are really specific to policies within domestic violence shelter, or looking at how domestic violence agencies specifically have shifted away from abstinence-based approaches to include more harm reduction and combined programming. So while some of the findings from the research will be more generalizable, some are very specific to this context. As well, the agencies that were included in the research were situated in BC, Alberta, Saskatchewan, and Ontario, and the community sizes ranged from really small rural communities to large cities. So while there was a broad range of different types of agencies and different provinces reflected in the study, there may be some limitations that every province wasn't included, or if you work at a domestic violence agency, there may be pieces that don't exactly reflect what your work looks like. But again, all of the findings from the study really come from these interviews with professionals. And of the participants themselves included in the research, or that had completed interviews, 1 was an executive director, 5 were in management positions, 3 were harm reduction or addiction support workers within a domestic violence program, and 1 held a different frontline staff position. And then most importantly, moving into the actual findings from that research. So there were some key themes, the first being the motivation that led these historically abstinence-based domestic violence agencies to shift towards combined programming. And then the theoretical approaches that really ground what practice in this area can look like. Another theme looking at the specific policies and practices of what combined programming actually looks like in practice in the day-to-day. And as well as looking at the successes that agencies are finding doing this work, the barriers that exist to implementing combined programming in the way that agencies would like to. And participants were also asked to share opinions on what an ideal service model for this population could look like. So when looking at the motivations to shift towards combined programming, almost every single agency reflected in the study described that their agencies had historically offered these abstinence-based approaches where they addressed domestic violence, but when it came to substance use, they either excluded women from services, or that was the piece that they just didn't talk about, or wasn't allowed within the program. So when asked about what led their agency to decide to shift towards more combined programming, every single participant in the study, regardless of province, size of community, type of services that they offered, all really described seeing this really stark increase in complex and concurrent client needs in their communities in recent years. So participants reported increases in rates of domestic violence, increases in substance use, toxic drug crisis, increases in mental health challenges, lack of affordable housing, that all really placed really unanticipated pressures on participants' agencies without any sort of additional funding or resources to support that increase in needs. So with this increase in complex needs that agencies were seeing, it became really obvious that these historical abstinence-based approaches, while they maybe previously did meet the needs of the community, they no longer were appropriate to actually meaningfully address the needs of the communities presently. So there really was this necessity for agencies to look at other options and to look at other ways to engage in practice. So some participants spoke with the fact that maybe some agencies in their communities or in their provinces were more open or more interested to learning how to incorporate harm reduction because of the changes that are happening in communities. Their domestic violence agencies really don't have the choice anymore of whether they want to be abstinence-based or not. There really is this pressure and this necessity for agencies to shift services. And over half of participants also spoke to the impact of the COVID-19 pandemic in really both increasing needs in their communities as well as placing, again, really unanticipated limitations on agencies and really restricting the available services. And what was really important when talking about the impact of COVID-19 was that these rates of domestic violence and substance use and lack of affordable housing, participants really noted that this hasn't gone back to pre-COVID levels since the pandemic kind of ended. But really, we're seeing the long-lasting impacts of this and really a changing landscape of services. So because the landscape of services across Canada really looks different now than it did in the past, there really is a requirement for new and different approaches to practice. So there has been a lot of growing interest into how agencies can incorporate this into their practice. And then outside of the increase in community needs, participants also spoke to just a general growing understanding and available research showing that there's an interconnection between domestic violence and problematic substance use. So in looking at what motivated their agencies to make changes, participants really talked about just the fact that, in order to be more aligned with most up-to-date research and up-to-date practices, there really is a necessity to begin looking at this interconnection and how we can support that better. And then moving into the theoretical approaches that really ground this work. So any changes that were made to practice or policy in the interest of moving towards combined programming really were well grounded within trauma-informed, client-centered, and harm reduction approaches to practice. And I would imagine that many of you are familiar with these or have heard of these before. So what I really would like to share is just some of the details of what these approaches actually look like in the context of combined programming. So first being trauma-informed care, which we know is a service delivery approach that focuses on acknowledging the widespread symptoms and impacts of trauma while emphasizing sensitivity, safety, empowerment, and confidentiality, and actively avoiding re-traumatization. And what I found in the study was that trauma-informed care was really well established in domestic violence programs, that domestic violence professionals are really responsive to the needs of clients experiencing trauma and really understand the barriers that maybe keep women in that cycle of violence, are really responsive and show up with care and compassion and understanding when women are navigating domestic violence. And so in the context of combined programming, this really means that the same care and compassion and understanding is also applied to experiences of substance use. So maybe an agency, it was really responsive and really taking a really caring, understanding approach when it came to domestic violence. But when it came to substance use, there's really strict rules and expectations, and there's not the same understanding of the impacts of trauma that maybe have led to those substance use behaviors. So there really is this necessity to begin learning more about substance use, addressing the stigma that exists related to substance use. And some participants as well really described the ways that some of the policies around substance use that were really strict, really exclusionary, maybe really policed women's substance use behaviors in ways really just mirrors the power and control of domestic violence. And so there's a need to look at those policies in this interest of combined programming and trauma-informed care to address those needs. And then next, looking at client-centered care, which is an approach to social work practice that is guided by authenticity, acceptance, empathy, promoting individual client values and needs as the key goals and facilitators of the change process. So again, this was an approach that was really well established within domestic violence programming. And within the context of combined programming, this really means that professionals are having really honest, transparent conversations about substance use with clients. That substance use isn't something that's hidden or excluded, or that clients feel the need to be secretive about because they don't feel safe enough in the program to be able to share that that's what's going on for them. It's really about addressing the needs of the whole person and not reducing somebody simply to their domestic violence or substance use needs, and really allowing what that client is actually wanting and what they're actually needing at this time to guide case planning and guide what programming is going to look like for them. So there's this necessity to really examine historical policies and look at ways to be more flexible to better meet the individual needs of clients. And every single participant really emphasized the role of client-centered care in being a major contributor to program successes within the program. So I really can't understate enough how important this approach is, and we will really see the importance of this threaded through the rest of the findings of the research. And then lastly is harm reduction. So while trauma-informed care and client-centered care were really central to participants' agencies historically and presently, the most significant shift towards implementing combined programming was this introduction of harm reduction in the agency. So harm reduction is a value-neutral approach to substance use that aims to promote client safety and reduce the negative consequences and potential harms of substance use behavior without requiring abstinence or treatment seeking. And some of the practices specific to substance use from a harm reduction approach in domestic violence shelters may include just, again, having open discussions about substance use, making that something that's just always a part of the conversation, allowing clients to access services while they are using substances, providing information, education, and supplies to promote safer substance use, maybe safe storage of substances on property, as well as other practices that we will talk about. And previous research on the impacts of harm reduction approaches being implemented into domestic violence programs really supports that by implementing harm reduction, we can increase clients' autonomy, we can foster empathetic, non-judgmental relationships between staff and clients, which also promotes additional safety for those clients in programs. And another really interesting piece of this was participants sharing that, harm reduction isn't actually something that's new in domestic violence programs, that it's always been the approach that's been taken to domestic violence. And as we see in the quote that's included here, it says, at the core, what we do when we work with women who are fleeing violence is what is safest, what is the least harmful for you. So it's really about, again, same with these other two approaches, really threading that same approach to social work care to the substance use piece of it. So for example, when we're working with somebody who's experiencing domestic violence and they're saying, I'm not ready to leave this relationship yet, the response that person receives is, that's okay. How can we make that as safe as possible for you? What parameters can we put in place to make sure that you're going to be safe? And that same approach is what should be taken with substance use. When someone says, I'm not ready to stop using, I'm not in a place to stop using, that approach is, that's okay. How can we make that as safe as possible for you? And I think one of the really cool things when looking at these different approaches to practice is that domestic violence professionals already have all of these skills and they're really good at all of these things. So with some additional education and training and addressing some of the stigma and fears that exist around substance use, domestic violence professionals can be really successful in supporting women who use substances. And we will see all of these approaches and the importance of them kind of threaded throughout the rest of the webinar. So next, looking at shelter policies related to substance use. So this is the section that is the most specific to domestic violence shelter settings and is really more aligned with past research on harm reduction practices and how these abstinence-based shelter settings can begin to incorporate more harm reduction and shift policies to be more responsive. So some of the themes that we did see in the research was it was a consistent finding that substance use wasn't permitted on agency property, and this was really due to concerns for ensuring safety. So participants described that there was a lack of infrastructure in their shelter, that the shelter was never designed to support safe use on site, so there really was no dedicated space where women could go and use safely. Participants reported, not having any sort of medical staff on site to help ensure that clients were safe when they were using substances, or really any staff on site. That participants talked about, many times in shelters, somebody is single staffed, and it's not a reasonable expectation to have somebody managing multiple families in the shelter and also be able to ensure the physical safety of somebody who is using substances, as well as concerns for children in the same space where substance use is present, which I'll talk about more later in the presentation. But even though substance use wasn't permitted on property, there really was a desire for this capacity building. This wasn't because agencies did not want to offer that, but it was really because they're limited in the infrastructure and the resources to be able to do that. So what was really important with this is the language that's being used to describe that to clients, that instead of having these really strict kind of policing policies around substance use, that there's just open conversations around the safety concerns. And participants talked about the role of engaging in safety planning with women. So, if they're not able to use on shelter property? Where is somewhere safe that they can use? Can we sit down with people and actually talk through those plans? You know, in communities where there is a safe consumption site available, is that a resource that can be accessed? Can this shelter support somebody in being able to access that, to really make use as safe as possible? And especially considering the pieces of domestic violence, that when somebody's in shelter, we're often safety planning around going out into the community at all, to ensure safety from that intimate partner. So how can those same things be applied to ensuring the safety of somebody who's using substances? Participants also talked about if somebody did use substances on shelter property, that was really addressed through these harm reduction and trauma informed lenses. So instead of historical policies of saying, well, you used in shelter, so now you have to leave and you can't stay here anymore, really being able to sit down with somebody and have an honest conversation about their substance use, about what needs exist, and about how staff can best support them. And this quote that's included on this slide gives a little bit of a script of what maybe some of those conversations could look like. It was also a consistent finding in the research that women were welcome to access services while they were using substances. And participants did describe situations where maybe an individual substance use exceeded the capacity to ensure their safety in the program. And in those cases, referrals were made to things like detox, hospitals, to help ensure that that person was receiving the medical care that they needed. But in those cases, women were always welcome to return back to the shelter. And in cases where maybe somebody's substance use needs exceeded the capacity of the agency to be able to provide support to them, again, going back to these conversations of transparency and respect, and really ensuring to the extent that's possible that that individual knows that the decision for them to be referred to another service outside of the shelter wasn't because they were bad or did something wrong or their substance use is bad, but really that this has nothing to do with their value, and keeping that door open so that person can return to services in the future. Other ways that staff had helped ensure the safety of clients who are using substances is through wellness checks. So this would include staff maybe going and knocking on a door if they hadn't heard from somebody, to ensure that they get a response and make sure that that person's safe in their room. So when, you know, substance use is something that is maybe hidden or not talked about or not addressed, it increases the likelihood that somebody may be using in their room or going through withdrawals or whatever the situation is. And that wellness check is only happening once hours have gone by where staff haven't heard from that person. But if there is that honesty and transparency, and these are conversations that are happening, it actually increases the safety that if somebody returns to the shelter and they can say that they've used and they feel safe coming to staff with that information, that then staff can create a safety plan with them and actually, you know, set times to be able to go and check on them, that if something does happen to go wrong, that staff are way more likely to catch that early on than once hours go by without hearing from them. And one of the other things that I learned about through this research was drug emergency response devices known as Lifeguard Light. So this wasn't something that agencies had in place, but one of the participants in the study had talked about this being something that was kind of in the works in their agency. So it's a emergency response system that is set on a timer. So if somebody is using alone in their room, they can set the timer, use their substances, and then when the timer goes off, they can hit the timer to say that they're still okay. And if they turn the timer off, then staff are never alerted. Nobody knows that they had used this system. But if that person does not hit the button to say that they're still okay, that will immediately alert staff, and then staff are able to go straight to that room to check on the person and make sure that they're safe. So just other ways that we can help increase the safety of women who are using substances, which again is stepped away from this, these are the rules, you're not following the rules, you're kicked out of shelter, to, you know, maybe we have policies that women can't use in shelter, but what happens if they are? How can we make that as safe as possible? Because that's still something that is going to happen. And then participants also talked about other policies that maybe were separate from anything to do with substance use, but really created additional barriers for women who were using substances. So this was especially true for overnight and curfew policies. So many domestic violence shelters have policies around curfews or policies around how many nights somebody is allowed to be out of the shelter, really with the intention of ensuring safety, or really being introduced initially to ensure safety around domestic violence. So the expectation might be that, you know, everybody is in the shelter for the night by midnight, and this helps ensure that everybody has returned and everybody is safe. But at the same time, if we're telling women that they're not allowed to use substances on the property, and we're saying you also have to be here overnight by a certain time, that creates a lot of barriers and creates this time period where women aren't able to meet their needs without kind of breaking one of the rules in shelter. So, if a woman wants to follow those expectations and goes outside of the shelter to use substances and then doesn't make it back by curfew, they're still maybe facing consequences for not coming back by curfew. So participants really talked about the necessity to really examine these policies that they have. Some participants talked about completely eradicating overnight policies, or looking at curfew policies really specifically of like, do we need this in place? Why is this policy here? Who does it serve? Does it still fit that purpose? And really having a critical lens on what those practices look like. And then looking specifically at what the practices were within these agencies. So 4 of the agencies reflected in the study had developed a specific substance use staff role within their domestic violence programs. And one agency was the only agency to have a nurse practitioner on site, and that nurse practitioner assumed a very similar role to these harm reduction staff roles. So the specific roles of these staff included case management specific to substance use. And again, from that harm reduction approach of, what is this person looking for? What would best meet the needs at this time? How can we support them with any of those steps that they're wanting to take? And then advocacy, both with external services, so maybe healthcare, social services, whatever services this person is connected to, but also advocacy within their own organization. So really having that specialized knowledge around substance use to help advocate to other staff of what's needed, how can we best support this person in our program. The harm reduction workers also engaged in a lot of supporting clients with referrals to maybe outpatient programs, inpatient programs, addictions counseling, what other services they're looking for. Some of the harm reduction workers also facilitated support groups, which were again in this harm reduction approach. So not an abstinence-based support group and learning how to be abstinent, but really how can we make substance use as safe as possible? Can we share some information about substance use and about substances to help keep people safe? There was one harm reduction worker who had the capacity in their role to actually engage in drug checking. So this included being able to actually test substances with a client to ensure that they're safe before they're being used. And then these workers also engaged in counseling and staff training. So there was a really important role for this worker to be able to share some education about substance use, about the interconnection of substance use and trauma and domestic violence, to be able to provide naloxone training to address some of these stigmas and misconceptions that really helped just increase the competencies of the whole organization overall. And so obviously, in order to shift services in this way, it really requires additional funding and resources that oftentimes just isn't immediately available. So in order to address some of those limitations of the agencies, participants also spoke to the value and the importance of engaging in cross-sector collaboration as really a way to help bridge the domestic violence and substance use fields. So agencies talked about the role of this in addressing limitations of their agencies. So these referrals to outpatient, community clinics, addictions counseling, maybe AA or NA meetings, and also talked about the role of this collaboration to promote client safety. So again, in circumstances where an agency can ensure the safety of the physical safety of a person who is in the program, being able to use referrals to hospital, detox, safe consumption sites. And participants really spoke to the importance of building really strong partnerships with these agencies, of not just having a referral, but actually having a close relationship and being able to work in a lot of collaboration with each other. Some agencies were also talked about having collaborative case planning. So being able to actually set up joint meetings where maybe the harm reduction worker in the agency, the domestic violence staff or the shelter staff, maybe a sponsor or whatever other external services that person is accessing, and being able to have everybody all in one room to really work together to wrap supports around a client or wrap supports around a family. And in agencies where they didn't have a harm reduction role, that staff training and education really came from these external resources of having other agencies come in to provide naloxone training or to provide education on, overdose or substance use in general. And the other agencies that were included in the study that didn't have the capacity to develop specific staff roles for harm reduction also described engaging in really similar practices as the other agencies. But there was a really noted capacity difference when that could be a separate role. So in a shelter setting, for example, if you have one person who is managing the needs of 8 different families at one time, having a separate person who can come and really sit down with somebody and do really good in-depth work with them around case management or case planning for their substance use can be really, really valuable. And then looking at some of the successes that these agencies have found in implementing combined programming at an agency level, agencies really talked about the impact of having that training and education and collaboration across their staff and being able to have really consistent messaging and consistent policies across the staff as being able to reduce stigma and misconceptions that staff were carrying around substance use, which really had the impact of improving the overall capacity and competencies of their staff and of their agency. So when these different pieces could be shifted, agencies are really seeing that they were better able to actually meaningfully address the needs of their communities and really promote some of these client successes that they were seeing. So in terms of client successes, over half of participants described experiences or shared stories of women exiting domestic violence relationships or recovering from problematic substance use as successes that were really attributed to these shifts that they were making in the agency of when they were able to, keep individuals housed longer, keep them engaged with services longer because they were being more responsive to their needs at that time. It really facilitated and allowed women to continue to move forward in their own healing and exit those unsafe relationships. But what was even more important was that when abstinence is not the goal of programming, abstinence isn't the only outcome or the only success that's seen. So really from this harm reduction lens, being able to see that success can look really different for different people and might look different for the agency that is not solely these measures of exiting domestic violence or recovery from substance use. And some of these successes included really increased engagement in services when women aren't being discharged from services because of their substance use. They're actually able to stay in the program, build trusting relationships, connect with staff, engage in services. It also really supports the promotion of safety for clients, again, when they're not being discharged from services and then having to return to an unsafe situation. They're able to stay safer in the program. These harm reduction approaches and having wellness checks and having open conversations around substance use really allow staff to assure the safety of clients in a more meaningful way, as well as just increased connection to formal supports. Another piece that was really important when looking at successes for these programs is that the success may look different depending on the type of service that was offered. So for shelter settings, some participants talked about the fact that because there's such a short-term program, a success might be that that person has found somewhere else safe to go, and that has been the outcome of their stay in the program instead of them being discharged because of their substance use. Other participants talked about the fact that sometimes the extent of what they're offering in emergency shelter is just a safe, warm place to sleep for a couple nights, a couple of meals, a shower, and just meeting those basic needs, and then the person moves on from the program. But in those situations where that was the extent of services offered, participants talked about the fact that those clients continued to come back and re-engage in services, really showing that they felt safe and they felt comfortable and supported in the program. And whereas long-term programs, there was really this noted capacity and greater ability to support clients with their individual recovery goals because they're able to connect with the service for a long period of time when we know that recovery happens in community over a course of time. And then looking at the barriers experienced by agencies trying to incorporate combined programming. One of the most significant barriers that was seen was really the stigma and misconceptions about substance use and harm reduction. So participants talked about the stigma occurring at really all levels. So at a community and government level, when there is this stigma that's being held or this lack of support for harm reduction, which we see in multiple provinces in our country right now, that really impacts the available funding and support and public support from donors or whoever it is to really support the sustainable development of these types of programs. So it really limits what agencies are able to do. Participants also talked about the impact of this stigma coming from staff. So especially maybe staff members who had been engaged in the agency for a long time, had been really trained and grounded within these abstinence-based approaches and certain understandings about substance use and its connection to domestic violence. It was maybe a lot more challenging for those staff to adopt harm reduction and to move into these new combined approaches. And both past research and participants talked about the fact that a lot of these fears around safety and fears around substance use are really informed by this stigma and misconceptions about substance use. So participants really talked about the role and the importance of having education and really taking these open and honest conversations, not just with clients, but also with their staff, that in order to really effectively move towards these models of practice, they really needed to sit down with everybody and ensure that everyone was on the same page. That some participants talked about the fact that if an agency introduces new policies and says, okay, now we're harm reduction and this is what we're doing, but the staff themselves at that front line working in the shelter haven't adopted those approaches, it's really not going to reach the clients that it's intended to reach. So there is a need to work collaboratively with staff to help people really get there. And then one of the other, just the biggest barrier overall, I think, is that limited funding and resources. So the participants that I spoke to and these professionals in their agencies really had a desire to be doing more and could really see what the need was and really see how they would have wanted to shift their programming to better respond to clients' needs. But they were really limited in being able to do that, again, by the infrastructure of the agency to ensure the safety of clients, the being single staffed, having lack of medical staff on site, lack of funding to create these specialized substance use or harm reduction staff roles to add to that capacity in the agency. One of the largest barriers that was noted by every participant as well was really ensuring the safety of clients in the program, especially children in domestic violence shelters, and really looking at how do we balance supporting women who are using substances and being responsive to those needs, while at the same time having a shelter space where there are children present. And while there might just be limitations in that infrastructure and that model and that single staffing that really limit the ability to support women the way that maybe you would like to related to their substance use, there can be a lot of value in, again, those client-centered approaches and really having honest, open conversations with women about their substance use. That one participant had shared an example of somebody who had used in the shelter and then left needles out in the bathroom where they would be accessible to children. But that agency had like a sharps box in their office. So if clients wanted to use it, they would have to go to staff and ask to use it and ask to throw their needles in there, when the shelter had a policy around not being allowed to use in shelter property. So are there ways that we can have more honest and open conversations with clients where they can trust that if they talk about their substance use, that we're going to just work to create some safety barriers around that and not have any sort of consequence to that use? There is a belief from participants in the study that being able to have those conversations can shift a lot of those safety measures of being able to keep children safer in the space. Another limitation noted by participants was the mandates of their agencies. So participants talked about the fact that their agencies were mandated to provide domestic violence services. So if somebody comes into contact with their organization and they're maybe experiencing domestic violence, or domestic violence is a part of the story, but they're really presenting and main need at that time is related to substance use, that agency may be limited in being able to support them while also maintaining their scope of practice or maintaining the mandate that they're funded for. And really, participants talked about funding really being tied to the services that they're offering, really being tied to lengths of stay in shelter, where if somebody's experiencing problematic substance use, it might not be reasonable that they can move out of shelter the same pace that somebody who's not using substances is able to move forward from shelter. So there's a lot of limitations just placed on what the agency is mandated to offer. And then lastly, some participants described barriers that were really specific to geographically isolated communities or really small rural communities. And some of those barriers that were noted by two participants whose agencies were in really small communities was, yes, one of the main barriers in these geographically isolated communities was really not having other agencies in their service in their communities to be able to refer to. So if somebody's needs are primarily substance use, maybe they don't have anywhere that that person can go. So it really places additional strain on the agency to shift in whatever way they possibly can to meet those needs. As well, these agencies talked about the fact that there's just not enough people in their communities or people who have the skills or the training to be able to fill these roles, and really having roles that have been vacant for a number of months because there just isn't the people to fill them. So there was really additional strain on agencies that don't have, that are even limited resources than what other agencies would have. And then lastly, with the findings, participants were also asked to share their opinion on what an ideal service model would look like, kind of in the case that all of the funding and resources necessary were available. And what I found was that participants had really different responses or really different opinions on what an ideal service model would look like. So some participants shared the belief that having separate domestic violence shelters so that they could serve women who are experiencing domestic violence and problematic substance use in one shelter, and then having another shelter that could serve families and children, really with the intention of helping promote the safety of both of those clients and being able to respond more appropriately to the unique needs of those clients. Whereas other participants shared the belief that segregating services even more is just going to create more barriers and create more stigma around substance use. That the answer should be, how do we build the capacity to have all of these individuals in one space, and how can we address all of their needs together while ensuring the safety of everyone in the program? One other participant, when asked about an ideal model, really, instead of focusing on capacity within their own agency, really spoke to an ideal model being one where there is more coordinated services and more connection to these external services in their communities, and being able to bridge the domestic violence and problematic substance use sectors that way. And then all of the agencies that did not already have a specific harm reduction staff role really described the development of such a role as being an aspect of an ideal service model. But really, regardless of the opinion on what the structure of the agency should look like, it was a really consistent finding that an ideal service model is one that is really informed and grounded by trauma-informed, client-centered, and harm reduction approaches to practice. And I really share this section really just to say that we maybe don't have all the answers yet of what should look like or what the best case scenario would be, or that different communities and different agencies, what would be most ideal and most effective might look differently depending on the different contexts that those agencies are in. But when we're guiding our practice within these theoretical approaches, we're really, regardless of what the structure looks like, moving in the right direction and moving towards an effective model of care. And then sharing some of the recommendations from the research. So first is recommendations for individual practitioners engaged in this work. And unsurprisingly, our first recommendation is adoption of trauma-informed, client-centered, and harm reduction approaches to practice, and really adopting those practices in a meaningful and fulsome way, and in ways that apply not only to domestic violence, but also to survivors' substance use as well. Secondly, an emphasis on developing genuine, authentic relationships with clients, which acknowledges the nuances of client experiences and addresses client needs holistically. So this, again, was one of the main contributors to success for programs, that when we can just treat people with respect and with transparency and honesty, we can really get a lot farther in supporting people and ensuring that our policies are matching those practices. Third is engaging in ongoing professional development to improve competencies related to domestic violence and substance use, including an emphasis on understanding and addressing their co-occurrence. So in order to address these misconceptions that maybe inform fears around substance use, or inform maybe a discomfort to have conversations around substance use, or to know what we're able to offer people, really seeking out other opportunities for knowledge and training and skills in this area is really important. And lastly, continuing to think critically and challenge the historical policies and procedures which uphold stigma and exclusion to services for clients experiencing co-occurring challenges. So every single shift or every single change in policy that I described throughout the findings of this research all came from individual staff who saw the limitations and saw the barriers and wanted better for these women and really weren't afraid to challenge these historical policies and challenge management and challenge these cultural understandings about domestic violence and substance use, really to improve services available. So there is a role for individual staff to continue to think critically about the policies that exist and be able to challenge them when they're no longer working. And then lastly, some recommendations for organizations or for directors and management and kind of the decision makers within these organizations. So the first is ensuring that harm reduction approaches are aligned throughout all levels of the agency. So as I mentioned, if an agency decides that they are now harm reduction and put out a statement and decide to change their policies, but they haven't gotten the support from people who are working in the shelter or at the front line, it's not going to reach clients. And there really is a necessity that if an agency is moving forward with this, that they're really doing that in a way that's all in, and they're really doing that in a way where they're ensuring every level of the agency know what that looks like and have the proper support in order to engage in it. Secondly, reviewing policies and procedures to ensure that messaging aligns with harm reduction principles. So a lot of the participants shared that these historical policies, not only were they exclusionary, but they also had a lot of stigmatizing language of, if you're using substances, maybe that's somebody who is violent or fighting or yelling, or really just these stigmatizing misconceptions about what substance use may look like that was really embedded into their historical policies. So also looking at not just the practice of the agency, but what policies look like and what language looks like in those policies to support the work that you're engaging in. And then third, providing ongoing professional development opportunities, including formalized training procedures for new staff. So again, if an agency is committed to doing this work, there is a responsibility for that agency to ensure that their staff are properly trained, that they have the proper understanding and proper education in order to engage in this work in a meaningful way. And fourth, to build partnerships with external social service agencies to strengthen referrals and collaborative case planning. So especially where there's limitations of the agency to build capacity to create more substance use specific programs and supports, being able to strengthen those services with those external services. Fifth, focusing capacity building efforts on the sustainable development of addiction and harm reduction programs and staff positions. So we know that this is a huge barrier for nonprofits and for domestic violence shelters to secure any sort of funding, never mind ongoing sustainable funding for roles. But this is still a recommendation that we can see the value and see the additional capacity that's built when this role can be a separate role within the program. And to support this as well, number 6 is advocacy and awareness efforts at community and government levels to challenge stigma and misconceptions about domestic violence and substance use. So participants in the study really held this belief that if there could continue to be advocacy at a community level, that agencies could continue to talk about the importance of harm reduction in their programming, then that will hopefully shift public perceptions about these challenges and create more opportunity for funding and more opportunity for sustainable development of these programs. And lastly is collaboration with domestic violence and other social service agencies to share knowledge and resources to develop effective models of practice. So again, what I found in the research was that agencies were really navigating this in individual ways, and so many agencies are trying to navigate this and trying to figure it out on their own. So there really is such a value in being able to connect with one another and learn what other agencies are doing, learn what innovative practices they're engaging in, what's working, what's not working. So with this as well, as we end the webinar and move into some of the questions, if any of you from your own experiences in your agencies have answers to some of the questions or can share some insight from your own experiences in your agencies about what's working or what's not working, I would really encourage everyone to share that in the chat and use the chat to connect in those ways as well, that all of our services really improve when we're in greater connection and greater relationship with each other. And then just to summarize and conclude the webinar, I really just want to share one of my favorite quotes from the research that really sums up the whole point that I'm trying to share here. And that is, I think just for me, the answers aren't hard. They're probably hard to put into place, but they're very simple. Like, how do we do our work in a way that treats people, like humans with desires and interests and intelligence and all of that stuff? It's just so simple, but how do we get our system to shift to that? And I think when I first started out with this research, I was really interested and really focused in what the specific structure or program or policy would look like that would meet the needs of this population. And what I really found in doing the research was that what the structure looks like is far less important. And the agencies that were the most successful in supporting this population and the most successful in shifting their policies and practices were those that really just took this client-centered approach and really just were focused on how can we be in meaningful relationship with our clients? How can we actually listen to what their needs are and meet them with compassion and understanding and be open to changing the way that we're practicing and really looking at what we're doing so that we can best meet those needs. And I think when that approach can be taken into every aspect of practice, all of those policies and structures and barriers kind of all can fall into place in alignment with those approaches. So, with all of this research, I've really just seen from these professionals who are engaged in this work that there is really incredible change that's happening in this sector. And there's so many professionals that are so engaged and committed and dedicated to learning how to support this population better. And there are promising practices and there is information that can support people to do that, and being in connection with each other is a big part of that. But I really think through these promising practices and through this commitment, we can really ensure that we're offering specialized evidence-based care that this population really is deserving of. So with that, I want to conclude the webinar and move into some of the questions, if there are any questions. And I have some of the references here that are included in the slides that are from the thesis itself. And thank you so much for your time.
Thank you very much, Savanna. We at PADS and our member agencies and all of the professionals from different sectors who are on the line really appreciate hearing about this up-to-date research and how it connects to some practical recommendations. So we have a few questions on deck. I'll pose those to Savanna and hear her answers. And I encourage others to put any questions you think of in the Q&A box as well. Savanna will have time to answer a few more of those, I think. So feel free to put them there. But where I'd like to start is this question from the Q&A that says, how do you allow for substance use in a shelter while ensuring the safety of other victims and their children who are also in shelter?
I really appreciate that question because I think that that's one of the main challenges that every agency is navigating. And I think that that's where like substance use itself is not permitted in the shelter is one of the ways that we're helping ensure that safety. But I think it's such a challenging question to answer, I think, especially when we talk about children being in the space. There are some measures of safety that I think can be put in place. Some shelters had talked about having lock boxes or having lockers where some of those substances can be stored. I think that having really open and transparent conversations around substance use and really creating relationship where clients can build trust and talk about substance use openly is one of the main ways that we can help create safety. And from some of the participants that were doing a really good job of that, we're finding that that was actually really supportive in creating safety for the agency, that if somebody can talk about their substance use, then they're not having to hide that and be secretive about it, especially if the agency has historically been abstinence-based or clients are coming into the agency with the assumption that substance use is something that's not allowed and something that they need to hide, which places not only them at greater risk, but again, greater risk for the agency to children being exposed to substances and things like that. So this may be not a perfect answer. And I think with increased capacity, participants really spoke about, if we could have a safe place on shelter property where somebody could use and we had medical staff on site to supervise that use, that would kind of limit a lot of those barriers around women maybe using in their rooms or using in bathrooms or common spaces. So some of that I think comes down to increased capacity, and maybe building relationship with clients is an imperfect answer, but I think it's something that every agency is figuring out how to navigate on their own.
Thank you. That's a very helpful answer. And as you said before, if attendees have examples of how this is working or questions about their practices in their own agencies, please do put those in the Q&A as well, and we can get some of Savanna's feedback. So now on to a different question from one of the attendees asks, do you know if the community programming for domestic violence and substance use has changed for offenders of domestic violence, either for men or women?
That's a really good question. When I did my background research, I specifically was excluding services that looked at care for perpetrators. So my knowledge on that is fairly limited, I would say. From some of the research that I did look at, there were programs that were treating a family and treating all of those co-occurring needs that a family was experiencing. So in that one program that I did look at, they were also serving perpetrators and people who used violence, and as well as treating substance use in that context as well. And I know from these combined approaches and really taking this client-centered care and trauma-informed care and harm reduction and incorporating all of those pieces that I was talking about, that they were finding success in being able to address those needs for perpetrators as well. But I don't know what kind of shifts in that sector would have looked like.
Thanks for that. That's also an interesting direction for future research, perhaps. So another topical and timely question. When you say the landscape of services has changed, especially after COVID, can you speak to the increase or decrease of addiction services and their need in the community?
Yeah, another really great question that, and my professional experience was in domestic violence shelter and agencies. So seeing the impact of COVID, that a lot of community-based organizations did shut down or close services or not receive adequate funding, that we know in Saskatchewan specifically that funding for harm reduction and safe consumption sites is often non-existent. So there is obviously such a lack of needed services. And I think that that was one of the big barriers that was talked about from participants, that it would be great to have great partnerships with agencies that could take some of these pieces and we could work collaboratively together. But what do we do when those services don't exist? Where do we refer people? How do we ensure safety when we don't have those other services to support people? So yes, there's absolutely more of a need. And I think maybe potentially that's where domestic violence agencies have taken on so much of holding that nuance and supporting clients with substance use, because those safe consumption sites or harm reduction services aren't as available as they should be.
Thank you, Savanna. So another question, these are great questions. Keep them coming, everyone. So an attendee asks, how do you balance the safety and needs of those who use substances and those who are trying to stay sober?
Yeah, another huge challenge and something that came up in the research of that there was a quote that I had in the presentation and then I ended up switching it at the last minute, but a quote talking about, for some women, substance use and yelling and violence were things that were really traumatic. And how do we have somebody coming into the shelter who, yes, is trying to maintain their sobriety and maybe potentially being around substances is something that has a lot of trauma with it for that individual, and being able to support them as well. And I think, again, looking at like an ideal model of having some capacity to offer spaces for safe use, that can be kept a little bit more separate from women who are not using or who are actively trying not to use. But I think, again, it always comes back to the same answer I find every time I've been looking into this research of, when we take that client-centered care and harm reduction and are having really open conversations, if somebody is struggling around being around substance use, how can we have open conversations with use around use or around what's happening in the shelter with them, and then also be having open, honest conversations with women who are using substances to really meet the needs the best we can, which I can appreciate is not a perfect answer. And there's so much nuance and so much gray area with all of this that agencies are really learning how to navigate this. But when I was doing the research, I was really looking for, like, what is this specific fix? What is the thing that we need to be doing? And it really is really nuanced and really complicated.
Thanks for that. And now the next question relates to what you were just speaking about the complexity between clients who are trying to maintain sobriety, but also some of the practical strategies around this. So if clients store substances in lockers, how does access to those substances work? And if they have children in their care, how does this work in terms of safety and parenting? Are there any data on the impact this has on others in the shelter trying to maintain sobriety?
Yeah, there's a few different pieces to that question. I think from what I learned from participants who had some sort of a locker or a safe box, that person would have the combination, could access that when they were wanting to access it, and could keep whatever they wanted in that lockbox, and that wasn't being monitored or searched by staff, but they could keep kind of personal belongings or whatever it is that they wanted to keep in there. Can you repeat the second half of that question around
Yes,
women who
the
are not
next
using?
part was for clients that use substances and have children in their care, how
Mhm.
does potentially using in the shelter impact safety and parenting?
Yeah, there was actually one example that was shared by one of the participants where they did have, it was in a second stage program, and they did have a woman who was using substances and had children in her care. And what it came down to in it, that example was having really collaborative case planning with the child protection worker, with the staff, with the harm reduction worker in their program, and really coming up with specific safety plans that worked for that individual mom. So in that case, it was safety plans around if there was a need to use, can you let staff know? Can we make sure that your kid has somewhere to go? That she had plans around family members who would be able to provide childcare. And we're really able, because of having these really honest conversations about use and that not being something that the mom felt she had to hide from the child protection worker, hide from the shelter staff, that they were actually able to create a safety plan that child protection was on board with and was kind of had okayed, that they could continue to support this woman while knowing that she was continuing to use substances, that maybe that was, recovery from that was eventually the goal, but just where that person was at that time, being able to work really collaboratively and build as many supports around that mom as they could, they were able to actually maintain the safety of the children and the mom uh, through those really collaborative case planning.
Excellent. Thank you very much. And I think you've already spoke to this, but the third part of that, I'm just going to come back to in case there was more you wanted to add about if there's any data, maybe from your study or maybe from the previous research that you reviewed about the impact that harm reduction and substance use in shelter has on others who don't use or who are trying to maintain sobriety.
Yeah, there was one really good study. I can't think of the authors of that study right now, but I believe it was a Canadian study that looked at interviewing women who were accessing a domestic violence shelter that was incorporating harm reduction, and interviewing both women who used substances and women who didn't. And for the women who didn't use substances, there was a lot of reports that because the agency was being intentional and communicating that with everybody. And some of the other participants had also spoken to that of how do we communicate that we're harm reduction to everybody, and how do we communicate that we're harm reduction without creating more fear or making women who don't use substances feel like the shelter won't be a safe place for them. And again, is this, I think, education and addressing misconceptions about substance use and really explaining in detail how we do support everybody. But in that, going back to that specific study, from the women who did not use substances, they had really shared that there was really a non-judgmental environment from staff just in general, and they could see that staff were able to support all different women's needs. I think the one concern that those women had was coming to staff with concerns about other women's substance use and feeling that staff were dismissing those concerns, which maybe is that misconceptions that those women had, that they didn't understand what the staff were doing in terms of harm reduction to support them, or was that staff really dismissing those concerns? But I think it speaks to the need to have conversations with both of those clients and have a general understanding of, here are all the measures that we have to ensure safety. And also at the same time, domestic violence and substance use are really interconnected, and we are also going to serve this person who is using substances, and being able to address some of the fears that way.
Thanks for that. And I think maybe we'll come back and talk about this later in the Q&A, but about some of the training piece for professionals, but there's also that education and awareness piece for the other staff. or for the other clients rather. But so connected to that as well, do you have any guidance on the best way for agencies to introduce new policies if there's hesitation or there's fear amongst the staff about how harm reduction can work?
Yeah, and I think there was one participant that really went into detail of what this process looked like for their agency and the success that they had in doing that. And that was really being able to sit down with the whole staff and really the same way that we were approaching clients is really just having open and honest and transparent conversations that staff who maybe have concerns can voice those concerns and have those concerns listened to, and at the same time providing education and providing that information that's maybe needed, and also exploring, are there specific concerns that staff have and how can we put parameters in place to support some of those concerns. There was some research. There was one domestic violence shelter, I believe in Ireland, that they had kind of looked at before they had implemented harm reduction versus after they had implemented harm reduction. And one of the main concerns from staff was that this was going to make the shelter less safe, that there was going to be more reports of violence and staff were going to be less safe and clients were going to be less safe. And after they had implemented harm reduction, they interviewed these staff again and had found that there was no increases in violence in the shelter after implementing harm reduction. So I think research really shows us that some of those fears and concerns do come from misconceptions or maybe just lack of familiarity or lack of comfortability with individuals who are using substances. So I think a piece of that is the education and also beginning to incorporate that and really being able to see that incorporating harm reduction and serving individuals who use substances doesn't inherently make the shelter any less safe.
Thanks for that. Now, another question. How do agencies that support harm reduction decide what substances are acceptable to use or not use, given that people can experience such differences and extremes from any substance? Or is a substance and this isn't a consideration?
That's another really great question. I think agencies are really navigating that in individual ways that I think legalization is one piece of that. So some of the participants had said, we don't permit any use of substances, but especially in emergency settings where there is a lot of communal spaces, it was more consistent that substance use of any kind was not permitted in the shelter. But for second stage programs where women have their own unit and have their own housing, being able to use alcohol and cannabis were more common in those spaces, which I think was a piece of that was legality. But it's such a good point that what makes some substances okay and other substances not okay. So I would be curious if some of those, again, maybe misconceptions or stigma or beliefs about certain substances being more harmful or making people more violent versus alcohol, which is legal, but we know is connected to or can be connected to being violent or being aggressive for certain people, that could be the impact that has.
Thank you. Another question that the attendee asks, I believe that a harm reduction approach is more effective than an abstinence approach, but it feels like two different discussions around single women and women who have children in their care. In your research, were the moms being supported working towards sobriety in the harm reduction approach?
Another really good question. What immediately comes to mind was some participants, when talking about an ideal service model, they were specifically talking about, when talking about separating the programs, of specifically having a program to address the needs of single women who are using substances, and then a separate service for families with children. So I think that there's maybe that same idea around safety and substance use. But sorry, can you repeat the question again? I lost my train of thought.
Yes, absolutely. So it says harm reduction approach may be more effective is more effective than an abstinence approach, but it feels like a different discussion around single women and women who have children in their care. So in your research, were the moms being supported to work towards sobriety because of that need to parent?
That's a really good question, and I don't know that specifically came up in the interviews, that people were talking about harm reduction for clients in general, and some, like the one that I had shared around the mom that was using substances, shared some examples like that, but there was no, I guess, differentiation in my interviews with people about what that would look like. My assumption and what I did hear from the stories around moms who use substances was that ensuring safety piece. and what that looked like. That might look very different in an emergency setting where somebody's going to be moved on from the shelter right away, and being able to ensure the safety while that mom's using substances might be different versus a second stage program where there's staff 24/7 in the building and that mom is living there for up to 2 years and can have that safety plan that involves staff. And those longer term programs have more of the ability and capacity to actually support people in achieving their own recovery goals. So ensuring safety for families in an emergency shelter might be very different versus a long-term program where you actually have the ability to take a harm reduction approach, really support somebody with just increasing safety measures, and then maybe that stability and that additional safety may eventually lead to recovery, but we don't get to see that in emergency settings.
Thank you. Now, another question related to the safety of children. This comes from Alberta, and they asked, how could we implement a harm reduction model and stay compliant with the Drug Endangered Child Act? Of course, the provincial legislation is different across Canada, but I think you'll have some input into this in terms of the compliance with legislation and just safety for children generally as well.
That's such a good question, and I think something that is maybe newer and having to navigate. And I myself have been out of shelter work for a couple of years now, so I don't know or haven't experienced what exactly that looks like in practice yet, or what that looks like in terms of working collaboratively with child protection. So I don't know that I have. I wish I had a better answer for that, but I don't know what that looks like in the context of endangered child and what that would look like if it was mom herself who was using, and what sort of legislation and duty to report and things exist around that legislation versus harm reduction approaches in shelter in general. And I would be curious, I guess, if there was capacity to increase some of those infrastructure pieces to maybe not. I mean, creating space for safe use on site is a really big undertaking and it takes a lot of capacity to build, but are there ways to increase some of those infrastructure pieces to create more barriers for safety for families versus women who are using substances? I don't know. But yeah, something to think about, I guess.
Thanks for that. Now, I think you can answer the next question based on your own research, but maybe the existing Canadian research as well. And the question is, did the rural community research also include Indigenous communities? And maybe you want to expand in terms of just if there's other considerations based on the research for Indigenous communities or agencies as well.
That's another really wonderful question. I think the research specifically that I looked at was really limited in that respect, looking at the specific needs of Indigenous women outside of increased rates of domestic violence for Indigenous women. But it's one of the big limitations of my research, I think, just in general, that the provinces that were included were not Northern Territories and were not some of those communities that would maybe have a very different experience for service delivery. There were a few agencies in my research that reported that they served a high number of Indigenous women and that they had incorporated cultural programming as a really key part of their services that they offered, and really the role and the value in having that. But I would say it's one of the noted limitations of this research that it doesn't look specifically at the experiences of Indigenous women. And the rural communities that were kind of noted in the webinar were two agencies that I had interviewed whose agencies existed in rural communities. And in those interviews, I'm just trying to remember specifically, I don't believe that there was an in-depth conversation around the unique experiences of Indigenous women in those organizations, but more the lack of any sort of referrals or any sort of resources that agencies could refer to, or lack of staff to fill those roles. So it was very evident in interviewing those agencies that they were really strained in their capacity and really going so above and beyond to do absolutely everything they could for clients because there wasn't those other resources to refer to. So the strain placed on those organizations is really significant. And you can really see the commitment from those staff who are part of those organizations to do their absolute best and really extend far past what maybe their mandate is as an agency, because that's what their community is needing.
Thank you. Next question. I liked what you said about needing collaboration rather than just referrals. We do give referrals to services. What are ways that you have seen working well to move that more to a collaborative effort?
That's another really good question. I think some of the things that participants had talked about was actually, building that partnership in inviting those agencies into their own organization to learn more about their services and vice versa, going and visiting those organizations. Some participants talked about, I believe it was a detox center, and building a partnership with that agency to get to a point where they could have a bed available for the domestic violence shelter. So if a woman came to access services and was in a place where substance use was their primary need at that time, that they would immediately have a bed available so they could flee that domestic violence, have a bed available, and then be able to come back into the shelter. So I think it is reaching out and taking those steps to collaborate more, and maybe through those trainings or through, I know at the agency that I work at now, we've had a lot of different community agencies that come in and will meet with us, and we'll be able to talk about what our services look like, what our barriers are, what referral processes look like. And I think it just takes that relationship building.
Thank you. And so during the presentation, you also talked about coerced use and also sometimes the risks for victims and survivors associated with substance use if they use with their partner, and that's part of that relationship pattern, sometimes going back or barriers to leaving, and then success when you have a harm reduction model in shelter. So question to follow up on that is, are there additional barriers for women who use substances when they're leaving shelter to try to secure housing or other additional supports and services that are needed?
I think absolutely that there are, from my own experience working in shelter as well, that there's a lot of barriers that get created around substance use and maybe sources of income or ability to stay in one place. And like you talked about with that connection to the abuser as a big piece of that substance use, that if that's the person that's providing you substances, as much as you're trying to stay away from them because they're violent or they're not safe for you, if there is a need for those substances and you don't have another place to access that, you're going to go back to that relationship in order to meet that need. So participants really spoke about the complexities and how much more challenging it is. And I think that that's maybe one of the big barriers to moving people on from shelter into their own independent housing, is there's so many complexities that keep somebody in that relationship that maybe it takes more and more times of trying to access emergency shelter and trying to move forward from that before somebody is successfully able to exit that relationship.
Thanks for that. Now, I know we're almost at time, but I think there's time for just a couple more questions. And you touched on this, but just to go back to it in case there's more that you wanted to add, relating to your recommendation number 3 about professional development, do you have any specific thoughts or recommendations around what's absolutely necessary for staff teams for training? Because we know we have shift work and someone has to be in charge of the agency while others are in training, and different shifts, and then of course turnover and the need for that cross-sectoral collaboration. I think also there's the training, the philosophy piece, but then some of the specific safety strategies that you mentioned. So yeah, are there any key things that need to be elements of training?
I think one of the key things that seem to be pretty consistent across participants, regardless of the kind of the extent of harm reduction that they're offering, is that staff are trained in naloxone and trained to be able to respond to overdose, which again is at the bare minimum, being able to keep clients safe and alive in the program. One of the pieces that was really important for those harm reduction staff roles was creating formalized training for new staff. So anytime a new staff member came into the building, being able to provide kind of those specific pieces of, this is what harm reduction is, this is how we practice that. I think a really important piece of it would be the interconnection of domestic violence and problematic substance use. So understanding substance use coercion, which I think can really shift into that understanding and that trauma-informed perspective of understanding why somebody might be using substances and how that's connected to their domestic violence, as opposed to, these are the rules in shelter and you can't follow the rules and so you can't stay here. I think is a really significant piece. And then training around just ensuring physical safety in terms of overdose and withdrawal and knowing what signs to look for and knowing how to respond appropriately.
Thank you. That's a really good start for a training plan for agencies. And so, as Savanna mentioned before, when we share the recording of this webinar, we will also share her thesis for everyone who'd like to do more reading and see all of those recommendations and the findings in full. But as a final question, where can people learn, or do you have any suggestions perhaps of other places other than your own research where people might be able to learn more about harm reduction in shelter?
Yeah, absolutely. So Women's Shelters Canada from, I believe it was 2022 to 2024, had a community of practice of agencies across Canada that were learning and figuring out how to incorporate harm reduction approaches. So after that project, they've created a webinar series that goes into more detail of what harm reduction in shelter settings can look like and addressing some of those concerns around overdose and responding to overdose, as well as safety for children in the shelter. As well as some other resources that aren't webinar based. And then the Learning Network through Western University also has some different resources and webinars related to harm reduction in shelter settings. And then, like I said, not within my own research, but within the thesis, if anybody does want to look at it, in that background literature piece, there are a number of studies that are referenced there that there would be value in reading the whole article.
Fantastic, thank you. We'll share those resources along with your thesis as well. So on behalf of the team at PADS and our member agencies, thank you very much to Savanna Belitski for sharing her research and her expertise with us. And thank you to everyone for being here and learning with us. And that concludes the webinar.